Well, hello everyone, and happy holidays. This is Michael Miscoe with Miscoe Health Law for my final installment of the ChiroSecure Growth Without Risk presentation series this year. And I thought, being it to the end of the year, I should talk about some ways to mitigate risk in 2024, so you don't find yourself with the need to call me or somebody like me and have a successful year without any post-payment hangups. So for those of you that are still billing, we're going to talk about cash practices as well, but if you're still billing insurance companies, you need to be very thoughtful about who you're participating with. It's a good time to break out your contracts, review the medical policies, and make sure that you understand the requirements for documentation. You understand what they think is experimental investigational, that you understand what they think is not covered, what they think bundles with other things like manual therapy or massage, what their delegation policies are, because it becomes virtually impossible to comply with the rules when you don't understand what the rules are. So if you're going to have a New Year's resolution, enjoy your downtime certainly over the holidays, but this is a great time to get together with your staff, review these medical policies for the payers that you participate with, and even some of the payers that you don't. If your practice does sees quite a few of their patients, because understanding their requirements is quintessential to avoiding problematic billing and coding that is likely to get revealed during a data analysis audit, and by which you come to the top of the heap and they decide to send you a letter requesting records. Some problematic coding things that I've seen over the past year that come up with unfortunately just very common, and they shouldn't be. If you've listened to these presentations in the past, I'm not telling you anything new. Watch your level of CMTs. There should be diversity in the level of CMT that you bill. And for those of you that treat full spine, fine, wonderful. But billing full spine means that the patient's got a source complaint in each region of the spine, hopefully with an associated mechanism of injury. I mean, if they fell off a building, sure, I'll believe that they're a full spine case, at least for a while. But even though you treat full spine, many of you will do what's called cluster coding, and you'll bill the middle level, 98941, and you'll bill it all the time. And it looks odd. It's just unlikely that everybody's going to have a medically necessary need for treatment in 3 to 4 regions of the spine. It's possible, but is very unlikely. You need some 98940 cases. Generally your neck and upper back cases. Those are your 98940s. Your mid back, low back cases. That's where your 98941s come from. Depending on your patient population, maybe you see a lot of low back cases, but try to achieve some diversity in your billing profile. Take the patient's complaint, whatever it is that they're coming out with. Don't do condition creep. You know, if they're coming in complaining neck pain and headaches, don't ask them about how their low back is feeling, because they're going to say something and you're going to go ding, ding, ding. And now we got neck, mid back, low back, and every case is neck, mid back, low back, and you're billing 98941s all the time, and you're going to get audited sooner or later. Also, watch your billing with, your frequent flyers, because in every case that we do, there's always, the couple of patients. Sometimes when they do a probe audit, they only select these patients where the visit history is just horrible. You've seen the patients for years and years and years. They keep coming. The documentation doesn't do a good job. When there are breaks in care explaining why the patient came back, there's no mechanism. There's really no way to establish a start point that allows me to whittle down the course of care into just these 6 visits, where we would have a decent medical necessity argument. If a patient comes back after a period of time, treat them like a new patient. Explain what's gone on since you've seen them last, what mechanism or what brought them back. Hopefully it's not something wimpy like aggressive feather dusting or long car rides or whatever. slept funny on the couch. I know it happens, but it doesn't present an argument for a significant health problem that allows you to start a new course of care. Similarly, January 1st is just around the corner, and patients get new visits on the first of the year. And just because they get new visits doesn't mean that you have an authorization to start billing again. If they ran out of visits and you've been doing them cash, you keep them cash until they trip over the cat and do a head plant into the wall, strain their low back, lifting Christmas presents, something. But before you start billing a new course of care, make sure there's a reason to do it. Also, with your frequent flyers, watch billing profiles where you're billing, one and done, 2 visits and done, and then maybe a couple weeks later they come in for a visit. It's almost impossible to establish medical necessity for that type of care because it is predominantly palliative, given that it's relatively short in its duration. And while some payers like the one and dones and 2 and dones, just watch how many visits you're accruing over the course of a year. And remember, just because they get 20 visits or just because they have unlimited visits doesn't mean that you can bill for forever. You still have to establish medical necessity, and this is where digging into those medical policies and understanding what that means. It doesn't mean what you think it means clinically, just because they have symptoms. I mean, you have to establish a significant health problem, demonstrate through outcome assessment potentially that there's functional limitations. The care plan needs to be 3 times a week, 2 to 3 times a week for 2 to 4 weeks at least, and have established measurable and objective goals. And it is a huge documentation burden for just a short amount of care, but if you don't have it, they'll take the money back. As far as the care that you provide, be very, very cautious about your E&M reporting or evaluation management reporting. I've seen cases where patients run out of manipulation encounters, and either the practice switches to E&Ms or they switch to manual therapy in order to continue treating the patient. And as long as you can, establish, let's talk about switching to manual therapy. If you actually change your adjusting technique to something that merely mobilizes the spine or only performs traction or works on soft tissues only, and you're not doing manipulation at all, and your documentation supports that, and you can justify that the ongoing care is medically necessary, maybe you can pull that off. But when they see that you're going so many visits with manipulation, then you switch to manual therapy or you switch to E&Ms, it's pretty clear you're trying to bypass their coverage limit. Be very, very cautious because it will draw an audit. As far as E&Ms, bill and evaluation management service, when there's a reason to do it, something significant has to change that causes you to engage in decision making where you're changing your diagnosis, changing your plan of care, and that happens somewhat infrequently. Payers are becoming increasingly resistant to just paying for an EM when you do your monthly re-exam. A monthly re-exam is kind of a stupid concept because you should do re-exams when there's a reason to do one. They're significantly better, significantly worse. But decision making should be the byproduct of that E&M, and where it's not, they're going to take that money back. Your billing profile for E&M should not exceed 1 in 9 to 15 visits, but demonstrate when you do an E&M. If you're doing your typical SALT note and adding the word re-exam to the beginning, it's not going to get it done. They'll get recouped. The unbundling of manual therapy from manipulation, whether it's actual manual therapy performed by you, it's maybe trigger point therapy performed by an assistant or a massage therapist. That brings in delegation issues that have been especially consistent in the post-payment audit arena over the past year and have caused providers a lot of problems. Payers really don't like it. Where massage therapists, if you choose to employ them, my advice is keep their services cash. But if you feel like you have to bill it, just understand you've got a couple burdens to get over. First of all, medical necessity. 1-hour massages, head, shoulders, knees, and toes are almost never going to be considered medically necessary. Even if you're doing focal massages, be sure to write a very precise order telling them exactly what technique to do, where to do it, what muscles, and how long to do it. Without that, I can't justify that your billing of their services under your name and NPI is appropriate under what's called the Incident 2 rule. So if you are going to bill for delegated services, make sure you always have a very precise order telling that auxiliary person, whoever they are, exactly what they're supposed to do, and then we might have a prayer of saving it. The second issue with unbundling manual therapy or massage is the actual unbundling issue. Most payers consider them to be part of a manipulation when they're performed in the same area of the body as manipulation. That's not technically the rule, but that's how they perceive it, and it always gets a lot of attention. And then we mentioned the delegation issue. So and then, of course, the medical necessity issue as well. So there's a couple of hurdles to get through. It's not a great way to get an extra service. You're better off doing active resisted exercises where you can bill 97110. There's no bundling problem. The delegation problem's still there. You still need to write a precise order, but and make sure that that delegation is permissible under your state licensure rules. But the CMT 97110 code pair is not going to get as much attention as the CMT 97140 or 97124. And the 110 does not need a modifier, a 59 modifier in that code pairing with the CMT. So that's a safer way to go. Finally, also think about extremities. I don't have a problem with extremity manipulation at all, as long as the patient has a source extremity complaint and you do an extremity examination, do an extremity diagnosis, and do an extremity plan of care. And if they also have a spinal condition, you're going to do all that same work for the spinal condition. Unfortunately, most times where we see overutilization of extremity CMT 98943, the provider, the extremity manipulation is supportive of the spinal condition. There's no diagnosed extremity problem. There's no extremity exam. There's not even an extremity complaint, except for complaints radiating to an extremity, in which case you have to treat the source. Where it goes to usually isn't considered medically necessary. So be cautious of that as well. Finally, look at your billing profile and make sure that you're not always billing the same code sequences for every patient, every visit. It's very noticeable by a computer. There's expected to be some diversity. If you follow your exams, diagnose the patient properly, and then order care consistent with what the patient's presenting conditions are, you will get that diversity by choice. I realize it's a lot of work. It's why a lot of docs go cash. But if you're still committed to billing insurance in 2024, those are the things that you have to do, had to do, for many years now, in order to survive a post-payment audit. Mitigation is about avoiding the audit. Watching your billing profile is the one thing that you can do to help mitigate the potential of an audit. But if you're audited, digging into those policies, making sure you understand what they need in terms of documentation content, especially for Medicare. Medicare is all about the documentation content. So if you haven't gotten cozy with the Medicare Benefit Policy Manual, which is Pub 100-2, Chapter 15, Section 240, make sure you do so, or you can pretty much expect that they'll be asking you to pay all the money that you paid back to Medicare. Also, remember with federal healthcare benefit programs, which includes federal employee benefits through the Blues, federal workers' comp, postal workers' comp, TRICARE, Medicare, Medicaid, anything that's paid directly or indirectly with federal healthcare program dollars, any audit that exposes an issue for which there's likely errors in the remainder of your claims, you have a 6-year voluntary disclosure and look-back obligation. And if you don't do that look-back or that disclosure and refund on your own, then those claims potentially become false claims. So just be very, very cautious when you're billing federal healthcare programs. I've noticed this year the state Medicaids have become, especially where the benefits are very good, out in Oregon, California, Washington, those states come to mind immediately. Be very careful because they're being very aggressive in their post-payment efforts. Finally, for cash practices, while you avoid all of the post-payment things from insurance companies by billing cash, be mindful of your marketing, okay? Because being somewhat imprecise in your marketing or how you market can get you in trouble with your state licensure board. Also be cautious that you are doing sufficient documentation to protect yourself from medical malpractice liability. It is very easy to get lazy with a patient that you have seen for years and years and years. And I just recently had a client, a very, very competent doctor, in fact, got lazy, did a 12-visit care plan. The 12th visit, the patient was injured, and unfortunately, there wasn't an exam. There were X-rays, but his malpractice carrier is going to pay out some money. So you don't want to be hitting your malpractice carrier's hall of shame because you did not do competent physician work before starting a treatment plan with a patient. And remember, cash, non-cash, it doesn't matter. Anybody you haven't seen in a while, you start them out, do an exam, figure out what's going on, take the time. Trust me, if things go sideways later on down the road, you will be very happy that you underwent that additional effort rather than just assume because you've seen this patient for years that you understood what was going on with them. So that's probably all we have time for. I wish you a very healthy, happy, and prosperous 2024, devoid of any post-payment inquiries. And until next time, I'll look forward to seeing you again soon.